Jay Hall. I'm an audiologist.
I'm Bob Margolis. I'm an audiologist.
Well, Bob, there is a shortage of audiologists. There's not enough audiologists for all the patients. And automated audiometry is one option. How did you first, what inspired you to start thinking about automated audiometry?
It was an idea that germinated over a long period of time and started when I started my doctoral work at the University of Iowa in 1970.
Wow, that is a long period of time.
My first assignment was to work in Arnold Small's psychoacoustics laboratory, and he was doing masking experiments. He was measuring pure tone thresholds in the presence of various types of maskers. It was automated audiometry. We didn't call it that at the time, but the computer was down the hall in a separate room, had less power than my cell phone.
Right.
And the procedure was based on very solid psychoacoustics.
Mm-hmm.
So nobody questioned the accuracy of it or the appropriateness of it for psychoacoustic experiment. Dozens of papers were published. And 30 years later, I was the director of audiology at the University of Minnesota Hospital. And as I was testing patients, which I love to do, it became clearer and clearer to me that what I was doing was guided by a set of rules. And I could write the rules down. And then a computer could follow the rules better than I could. My interest started with, I want to make my clinic more efficient, but now has become more focused on increasing access to services.
Can you just identify, I would assume maybe reliability, maybe the time it takes them to press the button. What could you just tick off some of the quality indicators?
We learned, when we learned pure tone audiometry, you always learn, you test 1,000 hertz, 2,000 hertz, 4,000 hertz, 8,000 hertz, come back and test 1,000 hertz.
Just to check to make sure that you get the same results, right.
And then you ignore the result and then you go on.
Yeah, right.
So retest reliability is one, which audiologists tend to do, but not in a systematic way.
And sometimes cut corners because of time issues or what they perceive as time issues.
So that's an obvious one. Retest reliability is kind of an obvious quality indicator. Another one, as you mentioned, how long it takes the patient to respond. We took these candidate quality indicators and tested a bunch of people with conventional manual testing and the automated testing. And then by statistical analysis, we determined which ones are predictive of accuracy and which ones are not. So retest is a good indicator. Time per trial, just how long the patient takes to respond, turned out to be a good indicator. People who take longer to respond tend to not be as accurate or repeatable.
False positive, false negative, or?
Yes, false alarms. So when the method we use lends itself well to measuring false alarms. When we're testing manually, we all get patients that raise their hand when there was no tone.
Well, and I don't mind a few of those because they're really tuned in, obviously.
But that turns out to be, the number of those false alarms turns out to be predictive of accuracy. So that's a good one. We have another one that we call a quality check. When you test a threshold, you get a threshold. If you turn the tone up 5 dB, the patient should always hear that, right? We call that a quality check. And so we get a threshold, turn it up 5 dB. If they didn't hear it,
you wonder if they even heard it the first time.
We call that a quality check fail,
right.
And we retest that threshold and count the number of those. And the number of those is predictive.
And then all of these data go into a summary of maybe good, fair, poor, or something.
Right.
Like that.
So all of those, we get an indication of each one, which ones passed and which ones failed. And then they all go into a regression formula, which gives an overall quality of good, fair, or poor. And those terms are not just descriptive, they're statistically based.
Quantitative, too. Yeah.
A good result means that the difference between the audiologist's threshold and the automated threshold is within one standard deviation of the average of the group. Fair is between 1 and 2 standard deviations, and poor is greater than 2 standard deviations. So they're statistically determined, and so you get an overall quality of good, fair, or poor. I mentioned that one of the quality indicators that didn't make the cut was age. We thought that age would be, and it turned out that it wasn't.
To be honest with you, and I think you'll agree, I'm very happy to hear that.
Yeah, me too.
As I become more involved in this large multi-site VA-DOD study, now I've gotten into the nuts and bolts of AMTAS because I'm needing to make sure that all the people doing the testing who are not audiologists have someone to go to if they have questions, et cetera. Mm-hmm. And I you know, it's a perfect tool in that setting. And so I've come to appreciate not just the fact that you can get an audiogram, but the whole quality issue. And as an experienced audiologist, when I'm performing quality assessments, I'm looking at the same audiograms that were automatically collected and analyzed, so I have an opportunity to do just what you were saying earlier, the expert being compared to the automated. We're using a model for service delivery that's old. It's basically not much different than the model that Raymond Carhart was using. Mm-hmm. So we need to look at the outcome. How can we meet this demand? I would say we've got to have support personnel. We can't be providing each and every technical service when, truthfully, some of the procedures we perform are very, very simple. So support personnel would be one, and then I would have in the clinic an automated device so that, in fact, anything that could be automated should be automated.
A professional needs to use their time wisely, and their time should be used in the way that benefits the patient the most. In addition, if it made their practice more profitable, that would be
which usually goes
nice.
Hand in hand, right? Yeah.
Right. So the whole world is moving toward automation to make things more efficient and more cost-effective and more accurate. Our field needs to move in that direction with the rest of the world.